So coming to the scapula now, and we're on the small intestine channel. The small intestine channel comes up the back of the arm from the little finger. There's a zigzag over the scapula and then moves up into the head. So it's the most common channel to be used for rotator cuff type injuries. And we're going to find small intestine 11. We've got a couple of methods of finding this. The first method is to find the inferior angle of the scapula. Now, on this subject, because of the way he's lying, the inferior angle of the scapula is quite prominent. But if it isn't, what you can do is just move into the arm lock position. That brings the scapula up. Keep your thumb on there and then come back to make sure you're in the same position. Find the spine of the scapula. That then draws a line, and the point lies on the upper third of that line. The second method of finding it is to find our small intestine 9, which lies 1 chun above the posterior axillary crease, small intestine 10, which lies directly over the joint, and then form a triangle, and that point of the triangle is our small intestine 11 point. Choosing a medium needle, and we can either use a perpendicular insertion, or we can use an oblique insertion. So perpendicular depth would be 0.5 to 1 chun. When we're going oblique, it would be 1 to 1.5 chun. So we're finding 9, 10, coming to 11. Place the needle onto the skin, strike the needle rapidly through the skin. Tighten the skin to give yourself a nice firm drum, and then advance the needle obliquely. And we're around about 30 degrees to the skin surface. I'm going to manipulate the needle, and I would expect the Derchi sensation to spread across the shoulder towards the ear and down towards the back of the arm, in some cases as far as the little finger. As we come to take that needle out, we just support the skin, draw it in the opposite direction to the needle, and then dab the skin if we have any spot of blood. So that's our small intestine 11. So we're on the upper trapezius now, and we're focusing on the gallbladder channel. Gallbladder 20 lies at the base of the skull here. The meridian comes down to gallbladder 21, which is in the center of the upper trapezius. Now, the point itself lies midway between the spine and the tip of the acromion, and traditionally it's said to lie at the highest point of the muscle, so the thickest part of the muscle. And in fact, this point can often be a trigger point for the upper trapezius, and when we stimulate the needle as well as the Derchi sensation, we may get a small twitch response of the muscle beneath the fingers. Now, one of the dangers of this point is that if we use a perpendicular insertion on a lean subject, because the pleura comes above the apex of the lung, we can be placing our needle towards the pleura itself, and we endanger the patient by risking a pneumothorax. So we're going to place our needle directed downwards towards the couch, and we're going to ensure that we're in muscle by lifting up a muscle fold. So this would be a skin fold. Muscle fold itself comes in here. So I'm going to choose a medium needle, which is going to take me to a depth of 1 to 1.5 chun. And that's, although the needle is going to go vertically, because we're looking at the orientation of the skin, it's actually an oblique insertion. So a perpendicular insertion would be this direction. So by going vertically, we're actually using an oblique insertion. So I have my needle, take the plug out of the needle, orientate myself, spine and acromion. Midpoint of that line, I want the highest part of the muscle, which is the thickest part. Place the needle onto the area, strike the needle, and then lift the skin fold and muscle fold, and then stimulate the needle itself. As we allow that to come down, you can see that the angle of the needle is oblique to the skin surface. As we withdraw that needle, sometimes you'll find you'll get a small twitch response actually when you withdraw the needle because of the drag on the fascial fibers. So compress the skin down, make sure that we're having no spot of blood remaining, and then we're done. So we're on to our bladder channel now, and the bladder channel lies 1.5 chun from the centre of the spinous process, and that's the inner bladder line. The outer bladder line lies 3 chun from the centre of the spinous process. As we come up towards the neck, the two channels merge and then come across the head towards the inner canthus of the eye. We're using bladder 10. Bladder 10 lies in line with the rudimentary spinous process of the C1. So we find our occipital protuberance, which is our governor vessel 16, come down by 1 level to our C1, and that is our governor vessel 15. Now where we have the hair covering the area, what we can do is just use a folded towel to draw the hair away from the area so we have exposed skin for our clean field for needling. We're using a medium needle. We're going to withdraw the needle and then repalpate. So occipital protuberance down to the rudimentary spinous process of C1, coming out by 1.5 to 1.5 chun in slightly, so that we're 1.3 chun, and we're just on the edge of the fibers of the upper trapezius. And then we can strike that needle either perpendicular to 0.5 chun or slightly deeper towards 1 chun, angling towards the spine. So that's our bladder 10 point, and we can needle normally bilaterally. As we come to withdraw that needle, make sure that there's no spot of blood remaining within the hairline. Just pause for a few seconds to make sure that the skin has healed over and we have hemostasis. We're on to the gallbladder channel now, and we're going to needle gallbladder 30. And gallbladder 30 is an important point both for posterior hip pain but also for low back pain, as it's a crossing point between the gallbladder and the bladder channels, and both channels are involved in low back pain going through the buttock and into the leg. So by needling this one point, we're affecting 2 meridians. So the point itself lies on a line between the apex of the greater trochanter and the sacral hiatus. We divide that needle into 3, and then we're needling into the lateral third. So we're going to use a 40 ml needle, and we'll mark our point. So greater trochanter, sacral hiatus, divide into 3, go for the lateral third. Perpendicular insertion, 1.5 up to 2 chun. Now in terms of safety, it's a safe point, although we're going to quite a large depth, because the sciatic nerve is coming through the greater sciatic notch, and it exits the buttock midway between the greater trochanter and the ischial tuberosity. So we're above the level of the sciatic nerve. We're within the bulk of the gluteus maximus, and in actual fact this point can often be a trigger point for the gluteus maximus itself. So our gallbladder 30, quite a long needle, so as we withdraw it, we can withdraw it gradually, pressing the skin down with the tube with the other hand or with a Q-tip. So that's our gallbladder 30 point. So our bladder channel is in two branches. The inner bladder line lies 1.5 chun or 2 finger widths from the center of the spinous process. The outer bladder channel lies 3 chun, 1 hand width from the center of the spinous process. We're going to use bladder 23, which lies at the L2 level on the inner bladder line. So we're going to use a medium needle and we're going to do an oblique insertion angled towards the spine. So we find the top of our rim of the pelvis, come across to the L4 level, and then we can come up by 2 to find our L2. Alternatively, we can find our L5 as the most prominent dip coming from the sacrum, and then we can count up our levels once again. So this point is used as a standard point in Chinese medicine, but it's also an important trigger point for the longissimus portion of the erector spinae. So we're coming from 5 up to 2, coming across towards the highest point of the muscle, 1.5 chun from the center of the spinous process. We're angling in towards the spine, so it's an oblique insertion at 45 degrees. And we'll just stimulate that needle. As we come to remove it, draw the skin away from the needle to make sure there's no skin puckering, and then dispose of the needle. Check the area for any spots of blood.